So we're going to start doing passive intervertebral motion testing, and we're going to do the cardinal planes of movement that we assessed on the lumbar scanning examination. The first one we're going to start with is flexion. Whenever you're doing a flexion technique for the lumbar spine, you want the patient approximately 5 to 6 inches from the edge of the bed. To get them in the proper position, make a fist with your hand, put your fist where you want it on the bed, and then ask the patient to scoot up into your hand. That's going to be the best way to get them in the position that you want. Prior to doing your PIVMS, you should have marked your patient so that you know which segments are hypomobile, which segments are painful, or which segments are hypermobile. So you'll have a pen mark. When I'm treating patients, I've got a pen mark so I know exactly which segments I want to assess with my PIVMS by the time I got here. On this particular individual, I just marked all the spinous processes so you could see each level as I go through the PIVMS. But remember, on your regular patient examination, you do not need to do PIVMS at every single level of the lumbar spine. You only need to do them on the segments that you found a problem at in the cardinal plane of movement that the problem was found in. So you don't need to assess flexion, extension, rotation, side bending right, side bending left, if the motion in any or all of those was within normal limits and did not reproduce their pain. That would take you a very long time to do that examination on every single low back pain patient that you saw. So you choose the motions that reproduce their pain, showed a hypomobility or a hypermobility. And then you hopefully identify the segments by your PA pressures and your unilateral torsion tests in your lumbar scanning examination. As far as pain is concerned, the movement dysfunction you will visually have observed when you were watching them do their range of motion. So we're going to start with flexion, but for the sake of instruction, I am going to show you every single level. Now I need this table a little bit higher because it's a little bit too low. Whenever you're doing this kind of work on the spine, what you do not want is you don't want to ever be leaning over like this with your back over your patient. You will end up with a sore back by the end of the day if you do that. So always, if you need to get lower, bend your knees and keep your thorax straight. As I watch you practice, I'm going to nag you about that. Okay? The patient needs to feel like they aren't going to roll off the edge of the bed. So you put your arm, you thread your arm through their up arm and you say to them, I want your arm to stay here because this helps me make sure that you don't fall off the bed. You do not need to squeeze it, but just don't all of a sudden while I'm working with you, move your arm like that. So I need you to keep it right there. All right, here is her L5 spinous process. So I'm going to start with the L5S, L4 inner spinous space. I'm going to be palpating right in that inner spinous space. I'm going to grab her ankles. I usually grab the bottom ankle, and then her bottom leg is going to rest on my right knee, on my right hip, so that her knee is located right here in the crease of my hip. And watch as I do this movement, how I move my body rather than use my arm. For some of you guys that are really strong, you might get away with using your arms. For some of us gals that aren't quite as strong or a little bit older, we need to use our bodies to help us do the work. Otherwise, again, you'll hurt yourself or you'll be really tired by the end of the day. So I grab her here, and I'm going to flex till I find flexion, and then I'm going to extend her till I extend, and I'm going to get in the middle. This is now neutral. So this is where I start. And I flex until I feel the superior spinous process of the segment I'm palpating move into my finger. So when that moves into it, because it's now opened up as far as it'll go, I'm done the test for that segment. I go back to neutral. I move up and go to the next segment. Flex till I feel it move, come back. in this particular patient, there is a tremendous amount of flexion at L4-5 compared to what I just felt at L5-S1. Now I'm going to go up to the next segment. Lots of movement here too. Go up to the next. Now it's starting to get less. Go up to the next. Now it feels more normal. So how much flexion is there supposed to be at L4-5, for example? Go ahead, Shauna, read it off. 13 degrees. So on this particular it's actually 3-4. L3-4 feels like this opens up much more than 13 degrees or 14 degrees. It feels like it opens up about 20 degrees here. So I can tell just from experience that L3-4 on her is hypermobile in deflection. Okay? So that's how, notice when I did these PIVMS, I did not do this. I didn't do, okay? I didn't do that. I started out at L5-S1, I found neutral. There's neutral. I rest her leg on my hip, flex her till I feel the motion stop at the segment above, take her back to neutral. Go to the next level. Come up, come back. If I want to repeat the same level a couple times, I can do this. Okay? Then I go up to the next level. So I always start at neutral, take them to end of range, go back to neutral again. And you can repeat an individual segment as many times as you want to give yourself an idea of how much motion you feel is there. So that is how you correctly do flexion PIVMS. Now let me demonstrate extension PIVMS and then we'll practice. For extension PIVMS, you need the patient approximately 1 to 2 inches from the edge of the bed. So you're going to make your fist, get it right at the edge of the bed, say come right up into my fist. Now to make your life easier so that it's not so hard to move her body around, she is relatively small, so it won't be difficult. But if I was working with a football player that was 6'5" and weighed 285 pounds, I would need all the advantage I could get in order to do these PIVMS and not be struggling just to manage that patient's body weight. So the way that I make life easier for myself in extension is this. I say to the patient, first of all, I hold their pelvis into me and I say, I want you to move this bottom shoulder backwards about 45 degrees. There you go. So do you see how I just pretty much extended her whole spine by having her do that? I thread my hand through her upper arm like I did before, and now I'm going to go to the legs. I'm going to be at the L5-S1 space again. I grab the bottom ankle like I did before. I still have her thighs resting on my hip crease the way I did in flexion, but I keep her knees bent towards her bottom because I'm going to take advantage of the fascia of the rectus femoris muscle to help me extend her lumbar spine. So all I need to do is watch the combined movement I do. I'm going to bring her thighs backwards. At the same time, I'm bringing her heels closer towards her bottom so that it looks like this. See that? So now I can very easily get her back to neutral, full extension. Back to neutral, full extension. And I don't have to work very hard to do this. Okay? So using this technique where you pre-position them in extension and you wind up the fascia of the rectus femoris to assist you will help you in doing PIVMS for your larger clients. Now let me demonstrate overpressure of both of these. Get back into neutral for me. We'll start with flexion. Okay? Let's say that when she did her active range of motion assessment in flexion, I reproduced her pain when I overpressured flexion. And let's say that when I did my PA pressures on her, I reproduced her pain at L4, L5. So I'm going to go to the L4-5 space, which is right here, and I would do my flexion PIVM. So here's neutral, there's full flexion, there's neutral again. I would ask her, as I do this, does that reproduce your pain? She says no. Okay, well then that means I now need to do a PIVM, a passive arthrokinematic intervertebral motion assessment, where I'm reproducing the glide that goes with flexion. As you know, flexion is a bilateral superior movement of both superior bones of the facet joint, or the zygoapophyseal joint, in the sagittal plane. So what I'm going to do is I'm going to get her to the end of range of flexion for this segment first. I'm going to flex her to the end of range. There it is. I'm now going to stabilize the superior segment using a pinch style grip. I'm going to lay my index finger and my middle finger on the lamina on either side of the spinous process of L5. And I'm going to do the best I can to stabilize from above, and instead of pulling this up, which I really am going to have trouble doing, I'm going to actually pull the bottom bone down. But that's the same motion as the top bone going up, right? I can either pull the top bone up or I can pull the bottom bone down. Either way, it opens the joint or flexes the joint. So I'll stabilize, and I'm going to grab her pelvis. Can you see how I'm doing like a posterior pelvic tilt of her pelvis? I'm accomplishing that by moving my body. I'll do it in a shadow demonstration in a minute. So this is the overpressure, and I would say, does that reproduce your pain? Hopefully, if everything is consistent, she would say, yep, now I'm starting to feel it. And that would match the examination that I had in standing. The shadow movement for that, I'm in this position. I've grabbed her pelvis. I've got it hugged into my trunk, and I'm doing this. So do you see how I'm turning my body? I'm not just doing this with my arm. I'm doing this. This is important to get in the habit of doing, because you will never be able to mobilize if you don't learn how to use your body. If you try to use your arms, you'll get tired really quick. Conversely, for extension, get you close to the edge of the bed now. Let's have you put your shoulder 45 degrees. Lift your head up. Let's say I'm going to check the PIVM at this segment right here. I extend her till as far as she goes. I'm now going to stabilize the superior bone again. I basically have the same grip that I had before for flexion, but this time, instead of doing a posterior pelvic tilt, I'm going to do an anterior pelvic tilt. So I'm going to do this. And that's a PIVM in extension for whatever segment I happen to choose here. To shadow do that, it was So flexion was this, extension was this.